Good afternoon. I'm Jim Bonnette. I'm from Oliver Wyman. I'm the Chief Medical Officer globally for Oliver Wyman, and I implement these models that we're going to talk about. As a matter of fact, I flew here from Singapore, where we'll be doing this same model in Singapore. No matter what country I go to, it's the same issue, and looking at the frail and vulnerable is a big deal. Our ideas on this concept and the things that we've implemented start with the patient first. So we're going to design a system with you today around a specific group of patients. But this system works for other vulnerable populations as well. So we're looking at care model innovation across the world. There's a lot of it, a lot of interesting things going on in a lot of countries, and a lot of innovation going on in pockets, which has been the real problem. We've never been able to spread at scale some of the innovation that has achieved remarkable results and should be used much more broadly, but we just haven't gotten there yet. The one that I want to talk to you about is called the Extensivist. And the Extensivist is a program that was invented in the United States in 1993. It has been continuously running since that time. It is the highest outcome Medicare, which is the elderly in the United States, outcome delivery system in the country. It has the highest satisfaction, the lowest complication rate, and the lowest cost. And in fact, where I've actually implemented this system, the cost of frail elders is the same cost as yours here, which means it's half what it is in the US normally. So looking at the kind of things that we think about when we think about innovation, there's multiple waves of innovation, and you're in several of these at once. So wave zero, where you're looking at quality and safety and making it consistent across the NHS, is the first phase you have to go through, although it bleeds into the other phases, pardon the expression. Patient-centered care, which is what I'm going to talk about, is really when I think about how do I design a system around the patient and their needs as opposed to the way the system is originally designed. And then consumer engagement, which actually is going to be a wave that's going to start here probably before you ever get done with either of these two, because people have different expectations for what and how things are delivered to them. And they act as consumers, and they're going to act as consumers in healthcare as well. And then the science of prevention, which realistically has real potential, but is priced out of the reach of most people right now. Looking at what the different kinds of innovation across the country and across the world, there are interesting pieces of experimentation going on everywhere. The trend is the issue for almost every country. No matter what level I start at, I can't afford a 6, 8, 10, or in some countries 18% trend. I was in Indonesia recently and it's 18% there. You can't afford it no matter where you are. And if you think about how care is delivered, if I'm sitting in front of you as a patient and you're my physician, you address my issues when I'm there, and when I'm not there, you don't really know what's going on with me and you can't manage me, and the system isn't designed to do that. And if I have chronic conditions or I'm frail and elderly, that's really where the system breaks apart. You aren't able to manage those patients in the 99.99% of their life that they're not sitting in front of you. So how do you do something different? And these systems are looking at ways to do that. You'll notice, if you can actually read it, small print, Kaiser's not on here. And I have a very specific reason for not putting Kaiser on here. Kaiser's a single largest HMO in the United States. It's also the highest cost in California HMO. And Kaiser has been unable to replicate itself. So I've watched 6 versions of Kaiser quit business in the United States. They've been successful in California and in Colorado, where they've been in business for 70 years. So if you've got 70 years to invest to create a Kaiser system, then that's maybe one you should look at. There are concepts that are valuable from Kaiser, but don't expect that you could replicate Kaiser. So here's the system that we've looked at and has been replicated multiple times in the US, and we're currently actually implementing outside the US. So you're looking at a population segment. Think about the population. Think about what kind of condition someone has, not specifically a named condition, but how many do they have and how sick are they? And segment that piece of the population out, and I'll explain why in a minute. Frail elderly, same thing. This also works for people with serious mental illnesses, autistic children, disabled adults who are not elderly. Each of these subsegments of the population can be addressed with an extensivist model, and the results are phenomenal every time. I've never seen one of these fail, and we've implemented them multiple times. I've been doing this since the 90s, and it's completely replicable in almost any system. You look at this group of patients, which is the next down the pyramid in terms of cost and complexity, and pieces of this model work there. So this model is actually scalable in different forms to different populations. It's very intense for the intense population, and it's less intense for the other population, but results in similar savings and similar improvements in outcomes for those patients. So here's the care model for the elderly, and think about it conceptually. Patients in the center. Every one of these systems that we design around the group of patients. There is a physician, which we call an extensivist. And I want to sort of depict what the extensivist job is that's different than a regular GP. There are very, very few people who can actually do this. It is a very special physician who has both the right empathy and skills to always manage the sickest of the sick, a high percentage of whom will die every year. So it's just a different mindset and capability set. The other thing that's a real change from the way most physicians practice is, I am never not responsible for anything about this patient, never. If they're in the hospital or they're in a nursing facility, they're at home, they're in my office, wherever, I and my team are responsible for the care of that patient. I'm responsible for making sure they get the right kind of care at the right time in the right place so they don't wind up in the hospital. And these systems for this patient will result in a 50% reduction in the use of the hospital and a greater reduction than that in the use of A&E. And it's replicable, it's repeatable, and it always works. Because you surround this person with the kind of things that they need. If you think about it, this is an incredibly expensive thing to do in terms of setting up services available for a patient who might have multiple needs compared to a regular GP's office. The thing to think about is, how much does it cost for a patient to go to the A&E in this system? How much does it cost for an admission? What are the complications that occur from admission that really isn't necessary? So think about it that way, and you balance those out, and in general, saving one admission covers the cost of all this stuff, because it's usually tied with an A&E visit as well, a change in medications, multiple other things that drive costs that shouldn't be there. This is from our modeling in a specific local health economy in the UK. 2% of the patients in that local health economy cost £5,800. I have set these up in the US where I have the cost for these patients to less than this, and that means I've cut it in half. So the kind of savings we're talking in the population the last one I set up was $100 million in the first year for just this small subset of people. So we're talking large dollar savings. But better than that, what we've had is a significant reduction in the utilization of facilities that basically, through preventive care, shouldn't have been done anyway, which means we've reduced complications. These patients in the US now have the lowest rate of amputations for diabetics, the lowest rate of admissions for complications of diabetes, the lowest rate of admissions for congestive heart failure. Any condition you name, this model will reduce the rate of admission and the rate of complications for that disease for them. These are the typical kinds of conditions that are in this model. At least 2 of these conditions. On average, people have 7, but you have to have at least 2 of them to get into the model. And you have to have had several admissions usually, several A&E visits. But when you segment the population, you wind up with roughly 2%. This has been consistent in almost every country that I've gone to. And the costs are really concentrated in this group of patients. When I've modeled it in different populations, the kind of savings I can get in this population spread across the entire rest of the population in a local health economy are sufficient to fund preventive care for the rest of the economy. So the savings are of such magnitude in this group that you can choose to make reinvestments of the funds to prevent other people from moving up the scale into this group. It's specifically very useful to start thinking in the patients who are just slightly less sick than this, and what would I do to prevent them from getting sicker? And there are sufficient dollars here to be able to do that. Think about the way that care is delivered now and how services are separated and how we don't communicate with each other. In the model, one of the requirements is that physicians and consultants must, and I repeat must, speak to each other. You cannot communicate by paper. You cannot communicate between you and somebody else to relay the message. The idea is if I need a consultant services, I would like to know what they're going to do. And I would like to help make the decision about what they're going to do because I know the patient and their family better than the consultant does. And I can help make a decision. If that patient is in the hospital, I'm going to follow them in the hospital because I know their wishes and their family's wishes and their other medical conditions more than the specialist does. A very different kind of approach. Again, I never abdicate responsibility for this patient to anyone. My team and I are always the people who are in charge of this patient. It's not a complicated office, not at all. It is roughly, depending on the size of the population that you wind up with, roughly 5,000 square feet. Usual kinds of exam rooms, education rooms, because education becomes an important, extremely important part of this, usually not done by the physician, by the way. An exercise room, because you should make the assumption that every one of your patients can exercise. The last time I went to one of these centers in California, I was impressed by the 90-year-old who was doing weightlifting, who was going to the Kung Fu class next. And the reason you do that is because you prevent falls. So where this has been implemented, the reduction in falls with injury is 80%. So how many hip fractures can you prevent? It's a big deal. There is a reason to have an exercise facility in here. And then you've got the usual kinds of exam rooms, and you have one special exam room. And I would recommend you think about doing this. And that is a specially trained nurse, no doctors, by the way, in this particular part, who does nothing but wound care, especially diabetic wound care. That simple change alone, and a highly trained, highly skilled person who does nothing else, results in that 80% reduction in amputations in diabetics. That person follows that patient always along until the wound is healed. There are almost never vascular surgery consultants involved, almost never. Where we've set these up, we don't use hyperbaric therapy either, and still get those kind of results. So there are significant things that you can do in intensive primary care. Think of this as an intensive outpatient care unit, run with a team of physicians and others who manage this patient and all of their needs. And again, it is an extraordinarily effective kind of mechanism. The other piece that's on here, and it's probably too small to see up on here, is that who does the pre-op clearance? Who knows the patient best? Who sits down and discusses with the family whether or not an elective procedure in a 90-year-old is the right thing to do? In this system, the physician here, the extensivist, is a participant in that discussion. It is not the consultant's sole job to sit down and discuss what might happen with surgery or what might happen as a result of surgery, nor is it just the consultant's job to talk about whether or not you should have the surgery. Because oftentimes the consultants don't know the wishes of the patient very well, nor the wishes of the family, who could be quite divergent from the patient and the wishes, and doesn't necessarily have the time to explain what's being done. This has been an interesting issue because Kaiser has been very good at mapping this out. When you actually give full disclosure to patient about elective procedures, in certain elective procedures, the rate of the procedure being done goes down by 70%. 70%. Because I'll give you a specific example. So if my complaint, and I'm an elderly patient, which I'm getting darn close to, is that my knee hurts and it's really hard for me to go up and down stairs. Well, you get the x-rays, and your knees, I have no cartilage left, personally, no cartilage left. So if I was to have a knee replacement, gosh, that would take away the pain. By the way, it doesn't actually help you go up and down the stairs any better, and it's still painful to go up and down the stairs. So if my major complaint was, I have pain going up and down the stairs, I would have a knee replacement because? So you have to think about these kinds of things. It's a very different approach to matching really what the patient and the family's needs are to what we can offer as a system. And again, where we've implemented this, there's a really significant reduction in elective procedures, and there's a significant reduction in all the complications associated with those elective procedures. This is the other piece. It generates significant savings that you have a choice to reinvest. So this is actual NHS data from a model that we did. You've got about 60 million in total patient cost for 1,600 frail elderly patients, which would be 2 extensivists, by the way, 2 to 3 taking care of these patients in that clinic. $50 million in non-extensivist costs, 10 million here. The actual cost of the extensivist is 2 million. The hospital costs go down by 6 million, so there is a loser in this system, $6 million reduction, 6 million pounds, sorry, a net savings of 2 million pounds. I think that the thing that comes out of this is that I can save enough money in this population, and I can get enough good results in this population to reinvest in the rest of the population in the local health economy, and I think that makes a huge difference. So what do we have? Basically, it's an aligned care delivery approach based on the needs of the patient, and it's based on a class of patients in terms of the complexity of their disease and their cost, which is the easiest way to pull them out of the system. You have aligned accountability incentives. So where we've set these up in the US, we also changed the payment scheme at the same time that we change the care model. Because realistically, you're spending quite a great deal of money to not spend even more money. So you have to change the payment scheme. It's no harder to change the payment scheme here than it is in the US, where much of it is set by the federal government and you have to go through waivers to be able to get anything changed. So it's just as difficult. There's no question that it is going to be a difficult task here as well, but you have to think about doing that at the same time. You have to have the supporting capabilities to make this work. So you have to have, as was discussed in a previous meeting, you have to have an IT infrastructure that helps you enable this. But you don't have to start there, but you do have to build it. Because you've got to be able to think about collecting all the data and making your decisions data-driven and preventing and predicting who's going to get sick. So electronic scales would be a perfect example. People with congestive heart failure are just as sensitive about lying about their weight as anyone else is. And so if you have an electronic scale, nobody gets to lie about their weight, and you can intervene before someone winds up in the hospital for congestive heart failure. You've got to have enough partnerships to be able to do this. So you've got to be able to work with all the right kinds of specialties and services, including social services, that help people do the right things in their life. We had a discussion in the last meeting about the care at the right place at the right time. And realistically, if you think about it, we currently talk to people about their problems and say, we would like you to do this because what you're doing is wrong. You're eating too many cookies, crackers, whatever else, your weight's up, your diabetes is out of control. Think about how that comes across, as opposed to, in this system, your problem is mine. I'm going to help you figure out how not to eat those cookies or crackers. It's a different mindset approach to how you interact with a patient, and they receive it very differently, and therefore the result is different. So you actually get a real result with patients changing behaviors. It's not a physician who does this, by the way, because not very many physicians are good at this. But to drive real patient change behavior, you have to meet them where they are, find out the reason why they do what they do, and help them design a way not to do it. You've got to have leadership in the system who's willing to do this. This is a real change. It's no more than the real change that occurs in the US when I set this up, because there are winners and losers. So you just heard me say the hospital's going to not have as many admissions. Specialists aren't either. So you're going to have people who feel this as a loss. You have to have enough compelling leadership to convince the physicians that this is actually to their benefit. So where this has been set up, the GPs who aren't the extensivists actually quite like it. And the reason they like it is because they're frustrated that they couldn't get these really sick people all the care they needed or get them to make the changes they always wanted them to make. So you move them to someone and a group who can devote the resources to be able to do that. And again, extraordinarily successful in getting the satisfaction levels up in providers. And then the ability to replicate and scale. This is scalable. All you need to understand is the geographic distribution of the patients and the local economics. And I can model this out and set it up and make it work. I distribute the centers where the geography dictates that the patients need them, not where I could put a hospital or an office. If that means I need to move somebody's office, then that's what I do. Because it's for patient convenience, for family convenience. And then you look at where do they need to be centered? How many do I need to set up? What's the access? And they're open 7 days a week, and they're open late at night, because my goal is to take care of the patient and not have them go to A&E and not have them go to the hospital. By the way, this program ties tightly to high reliability science. So this is a replicable model. It's the same kind of science that's used extraordinarily effectively to reduce risk and complications and errors in hospitals. And this does force reduction in those same kinds of errors because it is relentless attention to detail. And you have a team who's focused on that detail. And this has been scaled. The original company that started this in the United States started in California, and it's been scaled across the United States. The doctor who invented this worked for me. And invented the name Extensivist as well. And his company was sold several years ago for $850 million, not because of the patients, but because of the intellectual capital and the concept behind the design. And it's been replicated by other companies since then. And I'm sure you've heard of a lightweight version of this called ChenMed, which is a copy of this in California as well. So this is what it might look like. So how could you situate it in a local health economy? And it's in the slides you've got. You take a look at, again, at how the local health economy is distributed, where people live, where the services currently are, where the hospitals are. I don't put any of these extensivists close to a hospital, ever. Because my goal is not to use the hospital. So I never locate them in a hospital clinic, ever. Not ever, I would never do it. You look at the GPs and the concentrations of patients that they have, and you start looking at who's actually really good at doing the kind of care we just described, and you start thinking about how would I move things around to create the extensivist. So say you've got roughly 600,000 people, a couple of hospitals, 95 GP practices. What might you do after several years? It takes roughly 18 months to set up a fully functioning extensivist clinic and have it completely running full of patients. And full means between, depending on how sick the patients are, between 300 and 500 patients per physician, plus the team of people who deliver the care. And so what happens is you wind up getting a significant shift in where care is delivered for this target population of roughly 10,000 patients. So you distribute those across multiple physicians, roughly 20 extensivists, distributed, if you had the entire population in, distributed throughout the geography based on the geographic dispersion of the patients. And it doesn't work where there are too few patients, because you do have to have a concentration to make this work. So you may set up some versions, lighter versions of this with GPs in their office with traveling services to be able to help control the frail elderly and help manage them in the areas where you don't have a concentration. And again, as I said, I've done this now multiple places. I've been doing it. I was in practice since the 90s. I started off doing this. I didn't know what to call it when I did it before, but I only took care of cancer patients, heart failure patients, and AIDS patients before there were any medications, and so I didn't really have the healthiest group of patients. But this system does work, and again, I've done it in multiple kinds of economies in multiple countries. And when I go in and look, when I pull the numbers out and look at the numbers I showed you, that distribution and skew from the average cost to these patients is so radically different. Again, if you can change the outcomes for these patients, you can change the cost. And you can change the outcomes in a way that are very, very positive for the patients and for society. It's an interesting system. I'm surprised that it hasn't been more widely known. I'll go and do talks for 2,000-3,000 physicians in the US at a time, and maybe 10% of them will know what this model is. They just haven't heard of it before. And it's surprising because when I describe it to physicians, they get it right away. They all say, but how would you do that? Because it's complicated, it's hard, and how would I do it in my local economy or my local area? But I haven't found a place we can't set it up yet. And I have yet to see it fail. I think that's the other interesting part. It does take time, it does take effort. It makes total logical sense, and it's complicated to set up, but it's not really a complex idea. It's a relatively straightforward idea, but hard to do. But you could do it. You could do it here, and it would make a huge difference for you and for the population in the country. And I think that it would change the way that people think about the NHS in the sense that I'm actually not reducing services for sicker people, for people who need more. I'm actually going to increase the services you get. I'm going to change the place they're delivered, but I'm actually going to increase the services. And it is a way that you sell this to both patients and physicians, and it does work. So I think I ran over a little bit.
But you did really well.
Okay,
Yeah.
all right,
Right.
thank you.